is a continuation of just a review of the scoring manual. You know, this is a very dry topic, as you can all imagine, because it's all about rules. But you know, we got to do it, and it's good to have a general overview as you start to look at sleep studies, and hopefully this is a reference for you guys to refer back to when you need to. So the only part we didn't have time to round out from the standpoint of sort of you know, kind of sleep assessment is just looking at arousal. So if you remember from last time, we talked about sleep staging. But the last little bit part of this that I wanted to round out was arousals before moving on to some of the other signals that we have. So arousals, I think to some extent are easy to define and hard to agree on. So what you'll typically find, you know, is that from scorer to scorer, that there's a lot of variability from one scorer to the next. And it's better within a person, but even within a person, if I gave you a study to score 1 week and then I brought it to you a month later, there are still issues in terms of identifying those same arousals. There are both areas of omission as well as commission, if you will. So it's tough. It really is tough in terms of standardizing this. And you know, it's given rise to sort of looking at technologies like artificial intelligence to maybe assist us with respect to this, at least from a visual classification standpoint. Nevertheless, these are the rules at this point in time. And the basic definition is that there's an abrupt shift in EEG frequency to higher frequencies. So going to alpha, theta, beta, but not including spindles. Spindles are kind of a special exception of a higher frequency. And it has to last for at least 3 seconds or more. When you're in non-REM sleep, there does not need to be a shift in the submental EMG activity. It's just the EEG frequency. So that makes it a little bit harder to identify some of these. They can be subtle. And then the other point is that arousal must be preceded by at least 10 seconds of sleep, as defined by how we've looked at it previously. So what's the implication of that last statement? And it's an important one, which is that even though an epoch is scored as stage wake, you can score an arousal during a wake epoch. And that's something a lot of people won't do, and that is very ripe for a boarding question. At some point.
So you have majority of sleep, so you call that, majority of the epoch being wake.
Yeah.
And you call that wake, but there is that 10
There are
seconds of
little
sleep
snippets
and then arousal. I got it.
Exactly. And one other point I would sort of say with that first line, the abrupt shift in EEG frequency to higher frequencies, right? It's not atypical that sometimes, you know, the human eye is drawn to changes, right? We can establish a background in our mind and we see changes very immediately. And so sometimes one common error when you're starting to begin is you might see a sudden delta, for instance, or a slow wave of some type. And you might think that that's a shift or an arousal, and that does not necessarily mean that that's an arousal. You really need to look for a shift to a faster frequency. So this is an example, you know, from the original American Academy of Sleep Association's definition of arousals that was co-opted into the sleep scoring manual. But what you'll see here is really a epoch that has essentially 2 arousals. You can't see really you can maybe see the start of the first arousal. You don't see the preceding 10 seconds of sleep, but you can see that there's a shift to a fast frequency during this period. There does happen to be a shift in the EMG. And then you can see there's a period of quiescence and a slowing of the EEG for about another 10 seconds before you see another arousal occurring. There's some more subtle things going on within this. The main thing really is the EKG tracing here. And you'll start to see, right, that the EKG is faster during the arousal compared to the period during sleep, for instance. So these other clues can kind of sometimes help anchor you in terms of convincing yourself whether an arousal is there or is not. This is the slow part. There we go. All right. So what about defining arousals in REM sleep? The definition is exactly the same as in non-REM. The only difference is the second statement, which is that there should be a shift in submental EMG activity. And why do they say that? And the main reason is because we can see alpha activity during REM sleep, and that's a normal phenomenon within REM sleep. So it would be much harder to say that there are arousals if we relied on an EMG shift alone. And so part of the requirement is this EMG change. And then it only has to be 1 second in that EMG burst. So when you're in REM sleep, we start to focus on the EMG and particularly identify those arousals. So that's really the only difference you need to know between the two. Okay. So, here is an arousal in REM sleep. You can see rapid eye movements at the start of the epoch. The EMG tone is low. You've got your low voltage mixed frequency EEG that's occurring down here. And then suddenly you see a sudden burst in EMG activity along with that shift to a faster frequency. The fact that you see that shift in the EMG allows you to go ahead and call it an arousal. All right. Any questions there before we turn on to leg movements? Okay. So leg movements, you can look in the scoring manual, and they'll kind of go through the definitions. Much of it really was taken from a international consensus group that helps sort of define what the elements of a periodic limb movement are. But you can see there's a lot of components that you're looking for here. And by defining these components, it really does help, particularly for artificial intelligence, in terms of being able to identify leg movements, since these rules are present. But primarily what you want to do when you're looking for leg movements is that you want to establish a baseline. And so you can see that there's some baseline that's observed here, And then what you're looking for is that, to start the onset of a leg movement, it has to rise by a certain amount, which I believe is more than 2 microvolts. So as soon as the twitch of the leg, if you will, rises above 2 microvolts, we can call that the onset of the leg. And then, the leg movement itself has to exceed a certain absolute threshold above the baseline, which is typically 8 microvolts. And then the leg movement has to last for a certain duration, which is typically at least a half a second. And then there's an offset to the leg movement that has to be defined. And so that is then defined, and then that would help terminate the individual leg, the leg movement itself. And let's see if we can make the next part of this. So each leg movement, so the minimum duration is a half a second. The maximum duration is 10 seconds. I personally have never seen a 10-second leg movement. Others may have, but that seems to be on the extreme side. All right, my mouse is better. So the onset of the leg movement has to be greater than 8 microvolts above the resting baseline. The offset has to go below 2 microvolts above the resting level for at least a half a second. And then in order to call a train of periodic limb movements, you have to see at least 4 leg movements. Each leg movement should be separated by no more than 5 to up to 90 seconds. So a big duration range there. And if it's accompanied by an EEG arousal, the arousal must be within a half a second of the leg movement. Now, what's interesting here with this particular rule is that the arousal could precede the leg movement or could be after the leg movement. And that's different when we look at respiratory arousals, for instance. Those have to be after the event. So this is the one time where you can see a leg movement before, or I'm sorry, an arousal before or after the leg movement.
So Sheila, I have a real quick question. When you, if you have to see 4 leg movements separated by 5 to 90 seconds, if you see 4 leg movements, is that 1 periodic limb movement of sleep or 4 periodic limb movements of sleep?
Yeah, great question, John. Yeah, so those would be 4. It will be 1 train, but 4, if that was where it ended.
So the minimum amount of leg movements you could ever see and call it a periodic limb movement of sleep is 4.
Right, a total of 4, yeah. Yeah, that's for a total number. Now, right, that doesn't give you the rates. So if that was the only thing you saw 4, then you would divide it by, you know, the number of hours of sleep that you had to get your index. One other thing they sort of keep in mind, right? We're monitoring 2 legs, right? Left leg, right leg. And so if the leg movement is seen on 2 legs, both the legs, if you will, by less than 5 seconds, those are counted as 1 leg. Okay, so you know, you might see the left leg fire first, and then the right leg has a little bit of a delay. But if it's within 5 seconds of each other, they're counted as 1 leg. So here's an example here. So, you know, maybe going to Dr. Andressi's question. Sam, what do you think looking at this? How many periodic limb movements are there? I was gonna say, look at your purple channels in the middle, just to orient you.
Yeah, it looks like you have quite a bit of leg movement on the right side. It doesn't look like you have quite so much increase in voltage with the left leg leads. I'm having a hard time figuring out exactly how many seconds would be between them, but I would say it looks like they're pretty close together. So there are multiple, I can't say the actual length, but it looks like it's almost pretty rhythmic in terms of the frequency that you.
So let's just say there's adequate time between each of these things.
So it looks like it's a train of.
What's that?
It looks like it's a train of like.
Yeah, how many would you get?
How many?
Yeah.
How many would be considered to be in the train, or?
Yeah, or how many leg movements are you seeing?
I'm saying ones. Well, it looks like there's one at actually the very beginning.
Yeah.
So 1, 2, 3, 4, 5, 6, 7.
Yeah, I think that's right. Yeah, I think that's right. You got total 7 leg movements. You know, they're all part of a periodic train because there's at least 4 of them here, and so they would all get counted within that train. You know, I think also maybe embedded within Dr. Andressi's question, maybe I didn't pick up on it, is right. You can have individual leg movements as well that can be reported on the sleep study report, but we really mostly pay attention when you're part of a periodic leg train, or you know, when there's excessive numbers of leg movements.
So real quick question, if there was just 3 on this, in this, you know, picture, you wouldn't count it.
Right, they would get counted in the, I guess, the leg movement column, if you will, but they wouldn't be called a part of a periodic leg movement count. I think Kingman's got a chat question in here, just saying real quick, what is the significance of finding an arousal?
It's an old question.
Oh, all right, okay.
No, but so on this one, you know, that's a not a confusing part of it, but you know, these are all lawyers sitting around eating popcorn talking about this. So, you know, and John is correct. And that if there were only three, you would say, yeah, these are not, this is not a PLA, this is not a train, but there are PLMs, and you count the number of PLMs, and you'd still divide it by the total time of the study, but you would, you don't separately go into a train per hour, right?
Yeah, you could, right?
Well, you could, but people don't suggest that.
Yeah.
So usually what it is, if you got a lot of them, you got a lot of them. And
Yeah.
then the arousals are the important part.
Yeah. So speaking of which, yeah, so Ramat, since you're in the room, I'll pick on you next. You know, looking at this slide, right? You know, this, so you can see the EEG at the top. You know, we talked about arousals. Do you think there are arousals here?
It's already. Because I don't see.
I'm sorry, say again.
I don't think so, because I don't see a change.
Yeah, I think you're right. It looks pretty constant, right? Pretty steady. You know, unfortunately, I've got it kind of scrunched up, right? So I might give you a 30-second pop look for you to sort of look, but that is sleep.
Oh,
You get used to it, but you're right. You don't see really any changes. So you know, these leg movements are occurring in the absence of arousals. Excellent.
But I'm sure if you were looking at it at 30 seconds, there would be people that would find arousals in.
Whether they're right or wrong would be subjects of debate, I suppose, right? All right.
Maybe one that'll be clear cut. All right.
So here's just an example of a leg kick that you can see here in purple. And so here, this is 30 seconds that you're getting at this point. But here you can see that there's a leg kick, right? There's a change in the EMG. There's also a change in the EEG. It's occurring within a half second of the leg kick itself on the back end. So this would be a leg kick with an arousal.
Big leg.
Yeah, I can't tell you if it's a periodic leg movement because I'm not giving you the whole thing, right? But it is a leg kick with an arousal.
So in order for it to be a periodic leg movement, you would need three other like this. You would need three other leg movements to have it count. You need three more because that looks like I would call that just one.
Yeah,
Yeah.
exactly right. Yep.
And
This is a nice, I haven't given you enough information to say that it's part of a periodic leg trip.
Right. It's a 30-second alpha.
Yep. All right, so the mouse is killing me. Keyboard is killing me. All right. Let's go online here. Who's on? Rick, are you there?
Yeah, I think we're good.
All right, Rick. How many leg movements are in this channel?
I'm seeing 4.
Do they qualify to be periodic limb movements?
Yes.
Why do you say that?
The amplitude is high enough. That's number 1. Duration, by seeing at this 30 seconds epoch, I'm pretty sure it looks like it's more than 0.5 seconds.
Yeah, okay. So, yeah, so you see 4 here. So this is a bit of a trick one, because I haven't given you one other rule. And that's the fact that you got to look at the respiratory channel in relationship to these leg movements. And so one of the basic rules when you're scoring a sleep study is that, the respiratory events trump the presence of periodic limb movements. And so we don't score leg movements because they can be part of the arousal response. And so what you see, right, with each of these events here, essentially, is that with each apnea, right, and these are obstructive apneas because there's persistent effort, what you see is that you've got a leg movement that's occurring right at the end with these arousals. So in this case, the answer turns out would be 0 because of these respiratory events.
So I have a question about this. I remember this rule. Does it ever happen when you have a leg or limb movement that can trigger an apnea or hypopnea, or it's never happened that this way? It's always done the other way around.
It's a good question. You know, I suspect that you will see sometimes that occurring, but because of the way the rules are set, you will not be able to score it as such, because the presence of the respiratory event is going to trump those leg movements. But when you see leg movements that might trigger an arousal, that arousal could create a hyperventilatory response that could then, in theory, then lead into a disordered breathing event, perhaps. And so in that setting, you could, but unfortunately, the way the scoring rules are set, it probably wouldn't be counted.
There are 2 case reports that close the circle by treating the PLMs and getting rid of central apnea.
Yeah. Absolutely. Now, what you can do, right, is qualitatively, at the very least, in your sleep study report, you may not count these, but if you had that situation, Rick, you could qualitatively put in a statement that, you know, you suspect that the leg movements could be inducing an arousal-based set of respiratory events, you know, so something qualitative like that. But, you know, to Dr. Stroll's point, ultimately, you know, it's an intervention that's going to help you delineate whether those are true leg movements or not. All right, so additional points, yeah. So just like we said, respiratory events trump periodic limb movements. So we don't score PLMs during respiratory events, nor at the end of respiratory events. Just a couple of other things just to remember, the presence of PLMs does not mean that you have restless leg syndrome.
Yes.
I see this in a lot of sleep study reports from other institutions or sleep labs. And I don't want to ever see that in any of our interpretations, if you're sitting with me.
Could they be checking over the sleep history questionnaires that they they filled out?
RLS is a clinical diagnosis, not a PSG diagnosis. So 85% of RLS patients have PLMs, but 15% do not. The typical severity classifications that's probably most often used parallels to some extent mild, moderate, severe apnea, but less than 15 would be mild, 15 to 30 kicks per hour would be moderate, more than 30 would be severe. There is no evidence base behind this. This is just consensus. And just as a corollary, you know, just like PLMs don't mean you have RLS, the presence of PLMs don't necessarily mean you have quote unquote periodic limb disorder. And that really is a clinical diagnosis that needs to be made. We can talk about that another day.
I think Sally has a question, says for comment that our CMS patients have more PLMs based on this rule. I'm not quite sure which rule. I just thought it was interesting.
Yeah.
Sorry.
You know, yeah, I'm not sure I follow that. Sally, you want to comment?
Sure. So the respiratory rule for CMS is 4%. If you use the hypopnea ASM rule, 3% arousal. So you'll often find that when you're looking at CMS studies, you can't score the respiratory event. You have all these PLMs. And I think there was a study even to show that when scoring CMS versus ASM, you suddenly score more PLMs as a result.
Great
Yeah.
point. Yep, great point. Absolutely.
Got it.
Yep, okay, that's what Dennis was adding in. Okay. All right, and then Dennis Ockley, Dr. Ockley saying, so he's 100% agree that RLS is a history diagnosis. But if you see events that would meet PLM criteria during awake monitoring, that could be skipped. So absolutely, no question about that. So what Dr. Ockley is referring to there, that we don't really do well, but most of the time PLM scoring is done during sleep. You know, but there is data to show that if you score for periodic limb movements during wakefulness, that probably has greater sensitivity and specificity for the diagnosis of RLS than PLMs during sleep. It's somewhat hard to standardize the scoring of PLMs during wake to some extent. You got to do a lot of quality control to get it right with your lab, but if you can do it, it's a very nice way to help increase your sensitivity and specificity for the diagnosis. All right, we're gonna move over to respiratory scoring. Any questions on leg kicks before I go? Great discussion. One more point. All right, PLMs with arousal. What level? Eileen, I think we need to go to a bar and have a drink. Bottom line is, I don't know the answer. I will defer to any other neurologist or any of our other docs on the call that want to comment on this one.
So this is a big question I always have. I'm glad that you brought it up. So I was taught, rightly or wrongly, that 5 is your number. 5, you can have as many PLEMs as you want. When you get to 5 of the periodic limb sleep arousal index, that was a signal that you would say consider treatment.
Yeah.
I don't know if that's right or wrong. That's what I was taught.
Yeah. I think, John, that's what my mentors kind of roughly taught me. They gave me different thresholds. They kind of gave me, and I don't know where these numbers came from other than this person's gestalt, but it was like 6 PLM arousal index of more than 6 an hour, or more than 10% of 10% of the sleep study, they started calling it significant. But that's just arbitrary.
I think it would be nice to have, like, as we homogenize the service, that it would be nice to have a homogenized answer for 10%. So 10%. So Dr. Stroll, 10% of what exactly?
So
Number of PLMs,
leg kicks, yeah,
number of PLMs that produce an arousal, 10%.
exactly, yeah. Now, the question I think, John, really is, beyond just the threshold, really is the standardization of the language, because I think ultimately you don't want to overemphasize it because, people may do the wrong thing based on it, but you do want to at least have it, I think, somewhere in the report. I just worry about bringing too much attention to it because many times we don't know what to do with that information.
But you can't ignore it either.
Yeah, no, I agree. I think so. That's why I'm saying is the art of the definition or the interpretation is going to be important.
So that's what I've been told to put at the end. What I was told to put at the end of if I find that.
Yeah.
Number of PLMs with arousal is greater than 10% of the total PLMs and may contribute to sleep fragmentation. And so you say, well, what are the causes of whatever the contributing symptom is? The other is, if a person complains of leg kicks, do you say that's confirmed by your PSG?
I think this is a tough question because I'll be honest with you. Every time I go past the PLEMs on the sleep study and look at them, I'm like, what the heck do I do?
Well, you draw a ferritin level and ask them about whether they RLS the next visit.
Yeah.
I mean, I think, and those are why you have every year a debate between is PLMD a disorder, right? And you got one side, and you got other side, and you treat all these things. I mean, I don't know.
Yeah, no, I think that's absolutely right. At the end of the day, we probably intervene more in it than we probably should, I think.
Or we don't know how to intervene.
Yeah,
So maybe those people respond. I mean, everybody gives a lot of people gabapentin anyway. And they all say, well, that covers everything, right?
so many of them, to Denise's question. How many of them will go away if you treat flow limitation? Yeah.
Yes, that's true.
All right, so adult respiratory scoring. So these are the technical specifications here. So in order to score respiratory events, you need to have two signals under the AASM rules. You need to have a thermistor, and the thermistor signal is what you're going to use to define whether an apnea is present or not present. You also need the nasal pressure transducer, which is used to define hypopneas. And when the thermistor is non-functional, you use the NPT or the RIP and vice versa. If the NPT is non-functional, then you have to use your thermistor. So you use whatever you have. But in an ideal world, you would be using both together. I'll give my editorial comment here. And unfortunately, I forgot to include the slide to show you. But you know, the data is showing that there's a clear correlation between thermistor versus the gold standard, which is pneumatic airflow, is not great. There's a lot of variability in thermistor relative to pneumatic. Nasal pressure transducers are more close approximation of a pneumatic from a gold standard standpoint. The issue is that nasal pressure transducer falls down at the extremes of airflow. So when you see apnea on a nasal pressure transducer, there may in fact be airflow, which is why we use the thermistor to define whether apnea is present or not. There are ways to linearize the nasal pressure transducer from a biosignaling standpoint, and in fact, our system can do that. But you know, this is a subject where I'm not going to dive deep into it. I strongly recommend and I'll try to see if I can find a couple of papers for you, but really sit and try to understand the differences between thermistor technology and nasal pressure transducer technology so you understand the positives and the negatives of both of those things. Respiratory effort, the gold standard, we say, you know, at least on a sleep study, is respiratory inductive plethysmography. The real gold standard is going to be esophageal pressure monitoring, which is incredibly rare these days, but I dropped lots of esophageal balloons in my day, and yeah, nothing beats it compared to, you know, belts just don't cut it. It always gives you a better signal if you can do it. We put belts at both the chest and the abdomen level. And usually in the sleep lab setting, these are uncalibrated signals. But if you can imagine, right, what a chest and what an effort belt is doing, it's basically measuring the sense of tidal, right? We can, if we knew the baseline and we calibrate it to what a full breath is, we could measure a tidal volume essentially from it if it was appropriately calibrated. And so if it were, when you sum the effort belts between the chest and an abdomen, and you integrate that signal, you can actually get a surrogate airflow signal. And there's some systems that, you know, when the nasal pressure transducer signal is not working, but they have two belts, they may derive an airflow signal from those two effort belts for you. And so that can be a backup channel for you to look at. And yeah, if a thermistor is not working, use the nasal pressure transducer, the so-called RIP sum, RIP flow, or polyvinyl something fluorine sum channel, which is another thermistor technology. Yeah, I forget, I can't pronounce it.
Is that pretty clear to people? Because when this first came out with rib cage abdominal motion, the neurologist included because they didn't think it was interesting. So it's a two-compartment model. You can measure tidal volume, frequency, flow rate from measurements of the rib cage and abdomen to about a 92% accuracy if you calibrate. And if you can calibrate qualitatively by just watching what the, you know, what a breath looks like during the wakefulness.
Oximetry, as part of the respiratory scoring, should have a signal averaging time less than 3 seconds. You know, you'll see, particularly if you've been on the inpatient side, that oximetry in the inpatient side is a slow response system. Oximetry systems, usually with PSG systems, are fast response systems, so that we can correlate it to the preceding respiratory event. Hypoventilation would be monitored ideally by arterial monitoring, but almost impossible to do, or more typically end-tidal or transcutaneous CO2 monitoring. So let's see here. So event duration. So this comes straight out of the scoring manual. So, you know, how do we define, you know, when an event starts and ends? So the event is basically defined from measuring from the nadir of the preceding breath, or the peak of expiration, that is clearly reduced to the beginning of the first breath that approximates the baseline breathing amplitude. So you can see here, this red line, you've got sort of the peak of expiration, and then the offset of the event is the start of the next inspiration after the event. So the apnea duration, in terms of if you're going to call it an apnea, and you need to figure out, well, do I use the thermistor or do I use the nasal pressure transducer? Since an apnea is defined based on a thermistor, you use the thermistor signal. A hypopnea, in contrast, you would classify the duration based on the nasal pressure transducer. When you can't determine what the baseline breathing amplitude is, just because there's lots of breathing variability, events are terminated when there's a clear and sustained increase in the breathing amplitude, or there is a resaturation of at least 2% of the oximetry signal. So these kind of take a little bit of time and practice to internalize, but they're important. So this is just a decision tree I have kind of put together, you know, in terms of sort of thinking about how you classify respiratory events. And so, you know, really, you know, once you sort of define the beginning and the end, right? You know, so is there a reduction in airflow of at least 30% for at least 10 seconds? Okay. If the answer is yes, then you want to go ahead and look at your thermistor channel. And if the thermistor channel shows you that there's a reduction of more than 90%, then at that point, you're going to call it an apnea. Okay? But if the airflow is greater than 30%, but less than 90%, you know, you follow this pathway, and it's going to be some type of a hypopnea or a re-rapid. And how you define it is really going to be based on the hypopnea rules that we have. So we've talked about the Medicare criteria, right? So if the SAT declines greater than or equal to 4%, if it meets that, it's a hypopnea. Or if you use the ASM scoring rule, if it's a greater than 3%, or there is an arousal, we would also call it a hypopnea under that definition. If it doesn't follow those, we would follow the RERA decision tree at that point in time. Okay. Questions on that? That's just to classify it as an apnea, a hypopnea, or a RERA.
What's the gauge?
What's that?
What is you have the Medicare ASM gauge?
That's leftover from my old institution. Ignore it for it. You'll go crazy if I talk to you about that. The rules are crazy enough as it is.
Okay. You can add another
That's a
gauge.
sidebar from some session. The other part of the tree here, right, is that there is a reduction, but it doesn't meet 30%. Or maybe there's even an increase in flow. And so the question here is there an increased respiratory effort during that period of time with a flattening of the waveform that suggests that there's flow limitation that ends in an arousal and doesn't meet the criteria we just talked about for apnea or hypopnea. And so those events, those are called RERAs, or respiratory effort related arousals. They're essentially cousins of hypopneas or more subtle forms of hypopneas. Some people like to score RERAs, some people don't. You know, there's a lot of angst about the naming of these things. I really just consider RERAs and hypopneas to essentially be the same thing. But the amplitude criteria is really the issue that separates the two. So the next level of decision making is really going to be, well, you called it an apnea, you called it a hypopnea, great. Well, what kind of an apnea is it? What kind of a hypopnea is it? And so that's just what what this shows you here. So once you call it an apnea, we call it obstructive if there's continued or increasing respiratory effort. We'll call it a central apnea if there's an absence of respiratory effort. And then we'll call it a mixed apnea if there is an initial absence of respiratory effort, followed by a resumption of effort during the apnea. So for the most part, I think it's fairly easy when it comes to apnea separating out obstructive, central, and mixed for the most part. Hypopneas are kind of an interesting area, and sort of historically what you'll see is that most of the time we don't really classify whether hypopneas are obstructive and central. We don't currently do that in this lab. I think we need to start thinking about that. But usually then hypopneas are then assumed to be primarily obstructive when you score them. But that's not necessarily the case. Physiologically, there is no reason that you can't have obstructive or central hypopneas. And I dare say even mixed hypopneas, but I don't say that because that just confuses people. But these are the rules that the Academy has come up with in the scoring manual to separate out the two. And they're not bad. From an obstructive hypopnea standpoint, you have to have any of the three present, which is that you have to have snoring, you have to have the presence of inspiratory flattening or what we call flow limitation, or there has to be the presence of increased effort or paradoxical breathing. A central hypopnea, in contrast, is where you have to have, and this is incorrect here, there should be an absence of the three. The absence of all three of these should be there. And so there should not be snoring, there should not be inspiratory flattening, there should not be an increased effort or paradox. I think that last increased effort or paradox is the least useful or least sensitive to differentiate between the two. All right, so Roland, here's a tracing. All right, what would you see or call the majority of these sleep disordered breathing events? So I'll try to order you. Eyes, EEG, chin, EKG, chin, saturation, airflow. Here's your cannula, here's your thermistor, thoracic effort, abdominal.
So we still have thoracic and abdominal.
Remind you probably you should speak up a little bit. Yeah.
So just based on what we learned, looking at the airflow and the thermistor, it appears like there's a decline in both.
A decline in what?
In airflow and the thermistor.
Okay.
So the thermistor trumps the airflow, I think based on what we learned, so the
Yeah, right. I mean, there's a complete absence of airflow in the thermistor, right? Yeah. So we call it an apnea. Okay. So what kind of an apnea would we call this?
obstructive, but we still have the rest of it.
Yeah, exactly. And I think one of the things you can see here, I don't have the arrows, but there is paradoxing that's occurring towards the end of this. They're not in sync, they're actually countering each other. So that gives you increased confidence that this is obstruction that's occurring as well. All right, Sam, what do we got?
All right. Let's see, so you see, look at the airflow, you can see that there is essentially their period is just absence of see that during roughly all the events, I know there's like this little wiggle that's going on at least the bottom right, abdominal thing, but I don't think that's necessarily true effort. So I think throughout all of these events, you can see that there's almost like no effort in the thorax or the abdomen. We don't have a snort channel to see if there's any snoring. And you can also see that the SaO2, you can almost see a nice dip. It's not like a quick recovery, which would be more. So I think this is a central apnea, but I think that that dip also gives indication of a more gradual return as opposed to a quick return like we see with the
Yeah, I mean, I think it's a good, very, very nice pickup. And this saturation is actually happening a lot later than one would have expected. So there is a bit of a circulatory that's occurring here. But at least, core to the decision making, right? We don't need to know anything about that per se. But the fact, right, you said there's an absence of airflow in the thermistor, so it's an apnea. There's an absence of effort pretty much throughout most of these events. So that makes it central. So it's a central apnea. It's just by that. But yeah, there's some other things that definitely go along that make you more confident about. All right, Rick, what we got?
Right. By looking at both the airflow and thermistor, I'm seeing definitely flattening of both. I see a desaturation that's correlates with each flattening of the airflow events. But I do see a reduced excuse me, reduced thoracic and abdominal movements, but I still do see some very residual ones, especially on the first apnea, even on the left. Maybe the second one I'm talking about. There are some residual thoracic and abdominal movements there.
So apnea or hypopnea?
So yes, I'll call this definitely an apnea event because of the flow limitation of the reduced flow of the thermistor is less than 10%.
Okay, and is it obstructive, central, or mixed?
I'll probably call it obstructive.
Okay, because you see effort.
Yes.
What about this part of it?
I mean, that's the one I'm talking about. The second one is probably more of a, yes, that one's more of a obstructive, but the later two are a little bit more of a central event.
Yeah. So I mean, you actually have a central component, right? But the event isn't over because there's still no airflow. But at the end of this absence of effort, right? Now you've got effort, and it's paradoxical effort on top of it. So this is where you have a central and an obstructive component. So because there's both present within the event, we would call this a mixed apnea. So here, we can argue a little bit about, are these little PP efforts really true efforts or something else, just the belts wiggling versus the chest or the belly wiggling, I'm not going to argue on that one, but these other ones probably are a component of both a central and an obstructive event together.
Right.
All right.
Suzanne is also on.
Is that okay? So there, I was going to say Nicoletto. Suzanne, do we have any comment on this one? So the tracing is a little different here, so I'll just orient you. You've got your chest here where my arrow is. Just below it is the abdomen. Below that is the nasal pressure tracing. And below that is the thermistor tracing.
Oops, I think she dropped it. My bad.
Oh. All right, is Nicoletta there?
She's not that great.
Okay, all right, all right, go for it. So you just might have to speak up so we can.
Oh, sorry.
Yeah. Not just for our.
So, yeah, we already talked about what we're looking at, so nasal pressure, you lose flow there, but the thermostat looks like it's still picking up some stuff and trying to do a good job. So for me, I don't think it meets criteria for apnea, so I think hypopnea, right? And the question is.
So yeah, so right, so let's just start with that, right? So yeah, absolutely agree. It's a hypopnea. There's an absence of airflow of the nasal pressure, but you see clear-cut excursions within the thermistor, and it's not less than 90% of the overall thermistor baseline, right? So there's flow, right? And probably, right, you may have this person might be mouth breathing to some extent, maybe that's possible here. But yeah, so it's a hypopnea. Then, to your point, is this, what kind of a hypopnea?
Clearly the abdomen is not giving us effort, but the chest maybe reduced. And just going off what Rick had to interpret. It almost looks like for something that you put the end of the chest trying to pick up. So I honestly don't know how to interpret that.
I think you're right. We don't have enough information. I mean, you don't, unfortunately, right? Because the problem is you have an apnea in the pressure transducer, and you have a hypopnea in the thermistor. You would ideally see some airflow in the nasal pressure signal to be able to increase your confidence about whether it's obstructive or central. The odds are this is probably an obstructive hypopnea, but if we go through the rules, is there a snoring artifact? No, we don't see snoring artifact, but then again, we don't have a good nasal pressure signal in this case, to pick up on. We can't comment on respiratory flattening because there is no airflow in the nasal pressure signal. You don't see flattening typically in thermistors terribly often. They're just not that high fidelity for that. And then, when you look at effort, it's hard to tell. You've got paradoxing effort, the best you could sort of look for, do you have increasing effort? I could argue maybe there's persistent effort. I don't know if I see increasing effort. So it's a hypopnea, it's probably obstructive, but I can't hang my hat either way on that.
Is there a certain amount of, because I've seen a couple of sleep studies where I'm looking at it, I'm like, I can't tell if there's effort or whether or not there's not effort, because it's like there's something going on, but it's not like the textbook ones where in the obstructive, obviously it increases, it goes on, but.
Yeah, typically what's going to happen with most disordered breathing events is, right, there's almost always going to be a drop off immediately during the respiratory event, and then there's usually going to be a slow increase, throughout the rest of the event. That's sort of the typical thing. Paradoxing, when you see it, it's very specific for obstruction, but you don't always see it. Obstructed. All right. I'm gonna go through these because we're a little over time here. Quickly. But what do we have here? We have, all I've given you here is airflow, one signal here. So that's all you get. I'm also making it more confusing because inspiration is down in this example and expiration is up. But that said, what you do see here is that you do see flattening of the inspiratory waveform here, okay? So there's not an absence of airflow, so it's not an apnea, it's a hypopnea. There's flattening of the inspiratory waveform, so that makes me increasingly confident there's obstruction, as opposed to this being a central hypopnea occurring. And so, does a DSAT, I'm not giving you enough information, but there's no clear DSAT here. But there looks like there are arousals that are occurring repeatedly throughout. So these are obstructive hypopneas with arousals. These are, one example of what I would call central hypopneas here. So where things are marked in yellow. So there's a relative reduction in airflow. Again, inspiration is down, but compared to the previous example, you don't really see a flattening of inspiration. It just looks like a small regular breath. That's it. And that's essentially what a central hypopnea is. It's just a small regular breath. It doesn't have the flattening, but it's associated with a 3% desaturation or an arousal. So this is just a older stylized example. If you actually did esophageal pressure monitoring, this is what you would see. But in this case, on the example down below, now inspiration is up, expiration is on the bottom here. But with each esophageal effort, basically you can see that there's flattening of the inspiratory waveform. And the fact that there's effort tells you that this is obstruction along with that flattening. In contrast here, you do see efforts that are occurring in the esophageal waveform, but they're not increasing over the course of the event. And the inspiratory waveform in the nasal pressure signal doesn't look particularly flattened. Just looks like a very small regular breath. So this would be your central
missing
hypopnea.
of that flattening part, that's the biggest differentiator.
That's right. Yeah. So this top one is a central hypopnea, and this bottom one is obstructive. So just to round things out, this is how we define mild, moderate, severe. This is also not evidence-based, but it's just sort of consensus derived at this point in time. We have what we call the AHI, which is often sort of used as sort of the kind of the Medicare definition because Medicare doesn't allow you to include RERAs. And then there's the respiratory disturbance index, which is the sum of apneas, hypopneas plus RERAs divided by sleep hours. So big thing as you look at these, I think, is to sort of look at what is the difference between the AHI and the RDA, or the 4% rule and the 3%. And you'll see that there's some that they're very similar to each other, and there's some that they're very different from each other. And that tells you something different about patients. Treatment is not covered by Medicare if the AHI is less than 5, but private payers often will allow you to use RDIs or arousal-based events. Do I have a few more minutes here? Okay. Just to round this out so you don't have to hear from me again.
On this one.
On this topic. Yeah. So Cheyne-Stokes respiration. So Cheyne-Stokes breathing, we score a respiratory event as Cheyne-Stokes breathing if both of the following are met. There are episodes of at least 3 consecutive central apneas or hypopneas separated by a crescendo, decrescendo change in breathing amplitude with a cycle length of 40 seconds. I'll talk about that in a minute. And then B, there are at least a central AHI of more than 5 episodes per hour over at least 2 hours of reporting. That's the definition according to the scoring manual. So this is a nice example of a patient with Cheyne-Stokes respiration. So you see that you have apnea followed by crescendo, decrescendo, followed by apnea, crescendo, decrescendo, followed by apnea, crescendo, et cetera, et cetera. So this would be a nice textbook example of Cheyne-Stokes respiration. You've got at least 3 central apneas in this case, right? So this would all be part of that Cheyne-Stokes respiration. You know, the cycle length that's being referred to is really from you can pick where you start from, but the start of the event to the end of the hyperpnic phase, if you will, that's 1 cycle. Okay. And so if that's more than 40 seconds, that increases your confidence that it's Cheyne-Stokes, part of the Cheyne-Stokes training. Scoring hypoventilation. So monitoring hyperventilation is quote unquote optional, but we do it in patients we're concerned about it. But to score hypoventilation, it would have to fall under either one of these two rules. The first is that there is an increase in arterial CO2 to a value greater than 55 millimeters of mercury for greater than 10 minutes. And then the second is that there's at least a 10 millimeter increase in the CO2 during sleep compared to an awake supine value to a value exceeding 50 millimeters of mercury for at least 10 minutes. So if either of those criteria are there, you can call it hypoventilation. Again, these are just bare minimum definitions. Whether this is clinically significant hypoventilation that warrants treatment is a whole nother subject. And I think one thing I actually want to kind of bring your attention to as you're looking at these things is to really make a distinction between hypoventilation, which is chronic, versus quote unquote sleep-related hyperventilation or hyperventilation that occurs because you're asleep, right? So in other words, hypoventilation is a sustained increase in CO2 above normal, right? So these are patients with chronic lung diseases, muscular disorders, etc. Sleep-related hypoventilation, when we use that term, we're really referring to an additional rise in CO2 with sleep oxygen above what we would expect, right? When we go from wake to non-REM sleep, we expect that there's going to be a 2 to 5 millimeter increase in CO2. When we go from non-REM to REM, we expect another 2 to 5 millimeter increase in CO2. So those are expected levels of sleep-related hyperventilation. An abnormal increase would be more than 10 millimeters for a sustained period of time. So it's important to make that distinction in the reports. So this is just a tracing, just to show you that you can get. This happens to show you, sleep staging here. Here's your oximetry. Here's your CO2 tracing below. Many times we don't have the CO2 tracing, but we might see is just REM with these sort of episodic periods of desaturation that are occurring. It's sort of sustained hypoxemia during that time. But this isn't really sleep-related hypoxia. This is sleep-related hyperventilation, or more specifically REM-related hyperventilation. Because you can see during these periods of oxygen desaturation that the CO2 is increased during that time. So this is a nice illustrative example. And this would be a typical pattern we often see in chronic lung disease patients, COPD patients in particular. So